Hi, my name is Nicholas Kwok, and my project is on investigating the role of a ubiquitin B knockout in amyloid aggregation using a novel H9C2-derived cardiomyocyte model of transthyretin amyloidosis. Initially, my project experience was inspired by a patient who I saw suffer from the symptoms of transthyretin amyloidosis, specifically the cost aspect. She struggled to find a treatment that was affordable to her because the only treatments on the market right now are tafamidis, which is extremely expensive, even with insurance, up to $225,000 a year, and organ transplantation. So she debated physician-assisted suicide. This sparked my inspiration and curiosity to drive a research for transthyretin amyloidosis that was both more accessible and affordable to people in general. For some background on transthyretin amyloidosis, it begins in the left ventricle of the heart, which is responsible for pumping all blood to organs, and it is essentially the accumulation of plaque or amyloid fibrils inside of the heart due to protein misfolds. The only treatments, as said before, are transthyretin stabilizers like tafamidis, the #1 most expensive cardiomyopathic drug on the market, and organ transplantation. My project was divided into 3 distinct steps: ubiquitin tissue biomarking, modeling HTR pathology, and utilizing a UBB knockout for siRNA transfection to really test if ubiquitin B could be a biomarker for the disease. In the first part, I looked at visualizing ubiquitin B staining and expansion in cardiac tissue by doing 2 assays, immunohistochemical staining and Western blotting. When I modeled the HTR pathology, I utilized H9C2 myoblasts and differentiated them into cardiomyocytes utilizing retinoic acid and V122I transthyretin mutated supplementation. Finally, I knocked out the ubiquitin B gene by utilizing siRNA transfection to analyze the role of UBB versus no UBB within a cell. And here I used the MTT evaluation. For the immunohistochemical staining, there was a significant result as there was a compensatory mechanism for a lab cardiomyocyte, so there was an increase in ubiquitin expression when TTR tissues had. However, during the Western blot, there was a decrease in expression due to specific differences that decreased cell viability, which ultimately decreased the expression. My modeling was supported phenotypically, and my results for the MTT assay showcased a verification of the model. So I think that the conclusions from my research is that it opens avenues to decreasing costly therapies and safeguarding cardiac health by promoting more cost-effective diagnosis procedures and increasing distinct symptoms that make it unique from other general cardiac failures. Compared to industry standards, they're all significantly cheaper. Thank you so much for your time.